Well, welcome everyone. I'm Larry Gostin. I'm the uh, faculty director of the O'Neill Institute for National and Global Health Law and a professor of global health law at Georgetown University Law Center. Welcome very much to the O'Neill Colloquium and our Facebook Live streaming. So welcome to our audience and also to our students. Um, we're going to be talking about healthcare and public health reform in America. And the subheading was, do we know where we're headed? Well, it's almost laughable now because we don't. After last night's election, we're still waiting to see what direction the country will turn in. And of course, we have such consequential choices in front of us. Uh, Things like the Affordable Care Act and its sustainability in addition to all of its provisions, the most popular ones like exclusions for pre-existing conditions. We know that the Supreme Court is hearing a case out of Texas on this, and we don't know what the outcome of that is either. There are myriad other important issues like expansion of Medicaid, Medicaid work requirements, what the future of healthcare will be, for example, whether we'll have the public option or increased subsidies. But beyond access to healthcare, there is also reproductive freedoms and reproductive rights that are much discussed both constitutionally and through the legislatures, uh, as well as major public health implications. And these public health implications are as fundamental as the future of the famous case of Jacobson versus Massachusetts, and whether or not we can have religious exemptions from a broad array of public health measures, including measures like vaccine mandates. And then finally, of course, is the future of the United States approach to the COVID-19 pandemic and how that will shift with the election, and including, of course, our global health responsibilities and our relationships with the World Health Organization. So there's so much at stake in this election. We don't know where we are now, but we have with us most remarkable group of experts to lead us through it. We're going to be moderated very ably by Tim Westmoreland, who's been a professor at Georgetown Law, teaching in health law and federal budgets and legislation since 2001. Before that, he was senior policy fellow at the Federal Legislation Clinic, and he served as counsel to the Subcommittee on Health and the Environment in the U.S. House of Representatives, most famously working side by side with Congressman Waxman for major reforms of health in the United States. And last but not least, director of the Medicaid program at the Department of Health and Human Services. So we're well served by having Tim. Thank you so much, Tim, for joining us and ably moderating this. I'll turn it over to you. And then at the end, I'll say a few words of conclusion before we break. Thanks again, everyone, and welcome.
Thank you, Larry. I'm glad to be here. I'm not necessarily glad of the situation we find ourselves in, but I'm glad to be here with this group and a group of friends. I'm going to be short and sweet for this because we have a hard stop at 4 o'clock this afternoon for this gathering. So I'd like to begin by saying we're going to hear first from Diane Rowland, and then from Gregg Bloche, and then from Matt Rose. So if I could, let me begin by telling you that Diane Rowland is the former executive vice president of the Kaiser Family Foundation, and now emerita, and she is a recognized health expert on health policy writ large and a regular witness in front of the U.S. Congress, especially on issues having to do with insurance, Medicaid, and healthcare for low-income people. She's a widely noted authority on lots of different things. And she was the inaugural chair of the commission established to advise Congress on Medicaid and CHIP, the Medicaid and CHIP Payment and Access Commission, fondly known as MedPAC. So Diane, MacPac, I beg your pardon, Diane. I always do that. So what I'd like to do is to start with Diane. And Diane, how about five minutes or so to begin with, and then we'll move on to Gregg and then to Matt. And then we'll have some time first for questions and answers from students, and then for questions and answers from people who are watching this on other sources, Facebook. So Diane,
Sure.
please.
Well, it's a true pleasure to be with all of you today and to be thinking about something a little different from the election, although the election hangs over everything we will say and do today, because the future of healthcare has been very much on the ballot and continues to be clearly a big issue. But it's also very hard today to separate our way of dealing with the pandemic and the impact of the pandemic on the American population without thinking about what that means for the future. And for me and for many who have studied Medicaid over the years, the role that Medicaid has played in addressing the pandemic and being there, and the future of Medicaid, depending on what happens with the White House and the Congress, is really critical. And I think that the thing most important is that the pandemic really let us lay bare the inequities in our healthcare system and the importance of health coverage through Medicaid. I was also stunned that over the many years when Medicaid was always sort of a stepchild of Medicare, that we saw increased support for the program constantly in public opinion, though not so much in legislative opinion, including the many attempts to take it apart in the last Congress and the Congress before that. But I think that the most important thing to remember as we go forward is what will happen to this program. How will it be continued as part of the fabric of the American healthcare system? How will it be reshaped or reformed? And I think the important thing to bear in mind today is just how substantial that program is. Everyone thinks about Medicare as our major federal health program, but indeed Medicaid is truly our largest federal and state health program, but the amount of dollars in the program obviously come over half from the federal government. And I think that the populations that have been most affected by the pandemic are those for whom Medicaid is the major provider, including low-wage workers, essential workers, the low-income population at greater risk of underlying healthcare conditions, Black, Latinos, and whites who live in close quarters, increasingly our rural population where the healthcare system is so much more limited, and the frontline health workers, many of whom themselves are Medicaid beneficiaries. So what will happen to this program? Will it still be there as a safety net? Will it actually be expanded in some of the states that have not gone ahead? I mean, we've now seen 15 million people added to the Medicaid roll. That's been a very important part of addressing the pandemic in the 35 states in DC that expanded Medicaid coverage to adults without dependent children who were very poor. But will we see other states, now that the election has moved forward, decide that they too will expand the Medicaid program? Or will, and I know we're going to talk about that, will the decision about the Affordable Care Act actually take away the Medicaid expansion option that has made so many people that need healthcare and that depend on it both for economic security as well as for health security covered through the program? So I'm looking ahead and trying to decide what will this new configuration be? Will it be a White House that is continued with the Trump administration that has had Medicaid on its attack list, I think, throughout their administration, trying in some cases to block grant the program and to take away the entitlement that has allowed us to build on and expand that program to cover more and more vulnerable individuals. As Tim well knows, the coverage Medicaid could provide in the early days during the HIV epidemic I see very much like Medicaid's possible role in taking care of people who have now suffered and may be suffering the long-term effects of a COVID epidemic. And so I think that's one of the issues on the table. I think the other one is that the Trump administration has always looked at Medicaid not as a healthcare program, but really as a welfare program, trying to put in more restrictive coverage for individuals, saying the deserving poor don't include an adult who's really poor, who doesn't quite qualify as disabled, but doesn't happen to have any dependent children, and goes back to those Elizabethan poor laws for who should be eligible for coverage. Will we go back to some of that with work requirements and with limitations and asset tests and all the things that make it not really an available program to help the millions of people who have no access otherwise to healthcare coverage? Will there be ways to do new waivers to cap and restrict and change the program? Or will we have a Biden administration that can come in and actually build upon the Affordable Care Act and also shore up and reinforce Medicaid as part of what's in its toolbox to deal with the pandemic, as well as to help secure health coverage for more of the American population? And another piece of Medicaid that, of course, I think has been very important in the pandemic and would be a tool that could be used in the future is that this is a program for which the federal financing is a major source of revenue to the states that provide coverage to their residents, and has been used as an economic incentive as well as a health incentive for states, where then when there's a recession or when there's a pandemic, you can boost the matching rates and really provide some very immediate and direct financial assistance to the states. So I see that if the administration switches, there's a lot of opportunity to use Medicaid as a major part of the toolbox, not only to improve access to primary care and healthcare services, but to really address the pandemic and some of the issues of the pandemic. And I'm sure Matthew will talk more about this, but really what we also saw was the inequities in our healthcare system, the tremendous disparities, and the Medicaid expansion was beginning to make some inroads, not as many as we need, into addressing some of these disparities, allowing for some additional use of social determinants as a way of trying to shore up the kind of care that people receive early to help them lead healthier lives. And will that all be reversed either by the repeal of the ACA through the courts, or if there's a different president than President Biden, will that be a continuation of the Trump policies to try and cut back those services? So I think I wish we had answers to what's at stake. Obviously, the Congress seems to be retaining its House majority in Democratic hands, but not the Senate, so that a lot of the hope that one could offset some of the things like the ACA decision in the courts with action in the Congress may not be as possible as we thought before the election. So with that, I'll let others opine on the other challenges and issues, but I think watching what happens to a program that serves 1 in 5 Americans and is a really important part of our patchwork of healthcare coverage in America is one thing to look, how will it change in the future? Tim, I'll kick it back.
Thank you, Diane. That was a very good summary of what's at stake for low-income people and the level of uncertainty that we face at this point. So let me move on to Gregg Bloche, who's a nationally and internationally recognized authority on health law and is my colleague at Georgetown Law, and he's a professor of health law here. He's also the author of The Hippocratic Myth, Why Doctors Are Under Pressure to Ration Care. And Gregg has been studying these fields for a long time and was indeed an advisor to President Obama, both during the campaign and during the transition. So Gregg, what do you see is at stake? Where are we headed?
Thanks, Tim. And thanks so much, Larry, Jeff, and Tim for having me. I'll go for brevity to maximize our time for discussion. First, there's of course lots that we don't know about how the vote count and perhaps the litigation over it will turn out. I was pleased to see just a couple of minutes before we began at 4 that one of the, I believe it's the Associated Press, I may be wrong, but one of the main callers of the states has called Wisconsin for Joseph Biden, which is from the perspective of some of us in this group, a positive step. So Joe Biden now seems to have a much easier lane to the presidency than Donald Trump. And conversely, it's likely that Republicans will hold the Senate just barely. With these political probabilities in mind, I'll offer some bullet points. First, in the realm of healthcare, the importance of the Affordable Care Act case that the US Supreme Court will hear next week, California v. Texas, has jumped by lots. The case involves the question of whether, when Congress zeroed out the individual mandate tax penalty beginning in 2018, it left the mandate itself in place without the tax rationale for the mandate's constitutionality. Recall back almost a decade ago that the Supreme Court in NFIB versus Sebelius held that the mandate could survive as a tax, but not as an exercise of Congress's commerce power. So the mandate itself now matters little. After all, the tax is zero, so there's no teeth behind it. The threat to the ACA now comes from the argument that absent the tax, the mandate is unconstitutional, and that the whole of the rest of the ACA should fall because it's not severable, that is, the ACA is not severable from the mandate. Congress might be able to cut this off at the pass in January by raising the tax penalty for non-compliance with the mandate to, say, some tiny amount, say even $1. But a Mitch McConnell-run Senate is going to make this a heck of a lot harder. And if the Supreme Court takes down the ACA in California versus Texas, then enacting a replacement that achieves anything like the ACA's coverage gains without running afoul of the various SCOTUS-erected, Supreme Court-erected constitutional barriers will be much harder than this. We know from one thing worth underscoring about the ACA, part of its genius, but part of the problem here, is that it's about the most conservative way possible to pull everybody into a private marketplace. Single payer, of course, pulls everybody in via the tax system. Taxes are obligatory, right? So everybody participates. The ACA does so via a variety of incentives. It did so via the mandate previously. It doesn't have that tool now. And so that's why it's been impossible for congressional Republicans over the last several years to come up with a replacement for the ACA that provides anything like the coverage of the ACA. And it will continue to be impossible for any compromise group, no matter well-being, to achieve that goal. We know from NFIB versus Sebelius that 3 of the justices now on the Supreme Court have embraced the position that the individual mandate is unconstitutional, and that the whole rest of the ACA must therefore fall as inseverable. Justice Gorsuch would seem likely to join them. That takes the number up to 4. So if the ACA is to survive in California versus Texas, Justices Kavanaugh and Barrett would likely need to break with the conservative bloc on the severability issue. I actually think there's some reason for hope on this front, and this is something we could perhaps discuss if folks are interested during the Q&A and discussion. Okay, my second bullet point. A Biden presidency with a Mitch McConnell-run Senate would seem to doom Biden's public option proposal, which is a keystone of the Biden campaign's health reform plan. And notice the relationship here between the public option and Medicaid. The Biden plan would set up the public option as a free alternative for Medicaid-eligible Americans who live in the 12 states that have refused to expand Medicaid. And this seems unlikely to happen. And if it's unlikely that those 12 states, including Texas, if it's unlikely that they'll expand Medicaid, here we have this backstop, this alternative that was a cornerstone of the Biden plan for care for the least advantaged folks. We have that backstop being taken away because it's just hard to imagine a Mitch McConnell-run Senate allowing a public option to go ahead. Medicare for all or any other form of single payer is plainly off the table. In fact, the success that the socialism pitch seemed to have in key sectors of the electorate, most notably in South Florida, where I partially grew up, would seem to make it much more difficult to offer up any policy options that can be tarred with that socialism brand, however unfair that tarring may be. And Senator Susan Collins, who survived a fierce challenge, may well be the most important single political player in Congress on healthcare policy. She's at the political fulcrum in a way that's analogous to the role that Justice Anthony Kennedy played on the Supreme Court for many years. Third, Larry mentioned Medicaid work requirements. Under a Biden presidency, they're likely dead. That's, for many of us, some good news. Ditto for a bevy of other regulatory moves that the Trump administration took to make it more difficult to sign up for Affordable Care Act qualifying health plans via the insurance exchanges. But it's going to take some time to unwind these moves. The complexity of changing regulations and the constraints that the Administrative Procedure Act and related mechanisms create legally for changing regulations translate into a process that might well take years and might be subject to court challenges. Ditto for a variety of regulatory moves that the Trump administration made to make cheaper non-Affordable Care Act qualifying plans available in ways that risk throwing the individual insurance market into death spiral mode. I expect that those regulatory moves will be unraveled, but it's going to take time, and there's going to be litigation as insurers and others who have benefited from these relaxations of regulation challenge what a Biden administration would do. Finally and briefly, COVID. First of all, revelation. We've all been made aware in heightened fashion of the profound social and racial disparities in health that many of us have known about for decades, but America has not focused on. America has focused on these in recent months in a way that our country perhaps never has before. But action in this realm is going to be more difficult because of the Republican Senate. A party that can't even bring itself to recognize or acknowledge the concept of, say, systemic racism seems unlikely to move forward to address the social and economic determinants of health. I'm more optimistic about the prospects for immediate multi-layered action to tackle the pandemic itself. Acutely, I think we'll see the vaccine process move forward, and the outcome of that will be determined by the science. We can have more confidence in that. And I think this is maybe wishful thinking on my part, but I think we see it in the Biden plan. There's the possibility for a dramatic expansion of COVID assurance testing, hopefully to the point that it becomes universal. It's already been shown to work. Colleges and universities as vast as, say, the University of Illinois, Champaign-Urbana, with more than 50,000 students and staff, have reopened with minimal incidents of disease. Testing weekly or biweekly might be as close to a magic bullet as we can come. And one can truly expect the Biden administration to mobilize industry via the Defense Production Act and other tools to make these capabilities available. I'm going to stop. I look forward to our discussion.
Gregg, thank you very much. And again, hard questions and a lot at stake as we start watching the counts for the rest of the week. Finally, we're going to hear from Matt Rose, who's a longstanding HIV and social justice advocate. And he is the Director of U.S. Policy and Advocacy at Health Gap, the Global Access Project. He's also been before with the National Minority AIDS Council, where he worked on federal appropriations and federal authorizing legislation related to HIV and health disparities. Matt?
Thanks so much, Tim. People get ready because I tend to speak quickly. Sorry, not sorry. I think that there's actually a couple opportunities that I think are going to be open in the next couple of years, because there are areas where we're seeing rather different strategies approached. There's at least environments of moving on. And I think we can get legislation from even a McConnell Senate. First, would I'd say drug pricing reform. There is a desire to do work on this. We saw Chuck Grassley try very, very hard to move his bill forward and give people an opportunity. Mitch McConnell might just have to fold on this, but also there are a lot of actions that an administration can take on drug pricing reform that have nothing to do with Congress. And that could open up the possibility that we have some potential movement on drug pricing. We even saw President Trump attempt to probably engage in what might be slightly, I'm not a lawyer, so I'm going to call them illegal steps on trying to buy some votes with some Trump cards to bring down people's drug costs. Guess what? Didn't work. But there are some moves that can be made using existing authorities that could influence drug pricing on a number of fronts. Also, we can see this in the kind of the COVID space, that there is discussions about patents and rights held by the US federal government. That could be a very interesting space going forward. And the ability to have generic drugs within the market. We've seen that the Democrats have done a number of bits of thinking on this. And depending on how how aggressively you go, there are existing mechanisms that could do stuff. So for instance, you have margin rights that you could take. You could use 1492. There's options for you to get there that no one's really decided to challenge yet. And if your legislative options are off the table, this is the place you go. The second fun place where we might find actual work is surprise billing. Woo! Both parties agree that they kind of hate it, and legislation has moved forward in both chambers on this issue. Just none of it has moved to the floor, mainly because the Senate doesn't like to pass anything. But it is a bipartisan issue where people still have a belief that maybe you shouldn't get stuck with some $50,000 bill after you've already gotten your services and can't do anything about it. So an area where this comes down, all of this gets really squishy around who controls the Senate. There is still a path for the Democrats to have a slim, and by slim I mean a 50. Okay, maybe if you're getting real wild, North Carolina breaks, Cal Cunningham rides a wave, and you grab both Georgia seats. Like, you could do this and run the table to get to 51, but you're probably looking at maybe a 50% majority. It's going to be really slim, but that also means any legislation we're going to see on health policy is going to be around what does Kyrsten Sinema and Joe Manchin think is tolerable, because you're going to have to hold them together, whether you do a reconciliation package or whether you finally get rid of the filibuster. Next, we had the great discussion in this country about Medicare for all, and while that's a fun debate that's happening, there is literally no mechanism to get that done and through the House. Even though the Progressive Caucus in the House picked up several seats, that is not enough to override or getting a majority of votes to force Nancy Pelosi or whoever's in House leadership. But let's be real, it's going to be Pelosi for at least 2 more years, and then she'll probably step down. But none of them are going to take up that action, especially when we saw that there's not a mass movement for these things. So I say, not going to happen, but it's good. It should still be talked about. And the universal healthcare system definitely has its benefits. But as we also saw from the COVID situation, it also has its weaknesses. Countries that had multiple different kinds of healthcare systems didn't do significantly better, except for people like the United States who just do significantly worse because we don't like healthcare. Religious freedom. This is an interesting place to look at what HHS is going to be up to, and especially on the legal front, since I know most of you are law folks. We had a whole bunch of religious exemptions pushed on us and pushed through us in the healthcare space. A lot of these we could see getting rolled back, especially the kind of the global guidance that came out of DOJ that kind of said, you need to have religious freedom in the broadest interpretation across the board. We think that the Biden administration will probably do some more progressive things that kind of not only roll some of that back, but also do some interesting interpretations that could beef up, say, non-discrimination law. For instance, a lot of people are talking about, could you make it so that Bostock becomes the interpretation of sex discrimination for the federal government, which would have huge implications in healthcare settings. I'm going to actually save my last thing for last in the pandemic response. I will say that health disparities have gotten worse under Trump, mainly because people are, especially poor people of color, have been losing their health insurance, and because the South just is like very resistant to ballot initiatives and expanding Medicaid. You heard Diane Rowland speak on this before, really important program. The ACA massively reduced the amount of health disparities that we saw because people were able to get access to health insurance. This all goes away in a world where Trump wins his lawsuits and then after 4 years still does not give us anything that looks like a healthcare plan. And so Biden has the ability to at least stabilize some of the marketplaces with existing authorities, and that could be very helpful. Also, where I truly think that the Biden administration has the real chance to shine is we have hated these work requirements forever and a day, but those same authorities could be used to do actually proactive legislation in the creative spaces where we could see transformational policy happening at the state level that could be promulgated around the country with a little like nudge, nudge, hey, if you write plans like this, we will grant you said authorities, just like they did with all the terrible work requirements that Seema Verma said, hey, I want to see work requirements, please give this to me. Finally, the pandemic, a little bit of access to medicines. So one, back to what I said earlier about patent authorities, like this is a place where the United States government really needs to think about asserting its authority on patents to make sure that drugs are accessible. If you were to get the treatments that President Trump got in his response to the pandemic, you would be looking at 6 figures worth of healthcare bills. Most Americans not being able to pay for that. But most of these things are way in line with things that we have significant interest in. For instance, 80% of Regeneron's R&D has been covered by BARDA for the last few years. So we have some significant authorities that we wanted to enforce that we could bring down some of these costs, especially when you think about what's going to be needed for a global market. Because remember, people, it is a global respiratory disease. If you do not defeat it everywhere, you don't get to really defeat it or claim victory anywhere, unless you're cute and live on an island, because then you can control who can get to you. We're looking at you, Taiwan, and we're looking at you, New Zealand. I will also say one of the things, like a lot of people just want to always hate on the president, and I love to hate on President Trump, but sometimes he does set up things that are very helpful. So the authorities that Trump has authorized and created to fight the pandemic, so things like Operation Warp Speed could actually be good if you directed them, as well as the BARDA pre-purchasing. If we didn't buy a bunch of vaccines that may or may not work with them and invested instead more in testing technologies to roll out widespread universal testing in our country, we could be a lot further along. But because these authorities already exist, you can literally just redirect their targets and use those same structures to actually get a hand on things. Plus, things like the Defense Production Act have always been available to us and will continue to be available to whatever administration goes forward. So I would say there are a lot of places where there's kind of intersections that we can work on. There are some things that are going to be farther on the table just because the makeup of the House and the Senate right now, from what we've seen, is going to dictate more moderate policy. So even at one point I was going to say, Biden, if there's a big House thing, a fight, we could see that Biden would have to move maybe his public option a little more to the left to appease the House. That's not going to happen anymore. But I think that there is still room to get some things through. It really is going to depend on how we see breaks in in North Carolina and Georgia. And that's really going to be telling on if you have a Mitch McConnell or not. If you have a Mitch McConnell, life gets a whole lot more dicier. But remember, one of the things that we haven't done as a country that we probably should do as a country is like reel in the executive power and authorities we've made over the years. But for now, we can use those in our favor. Now it means because also they've remade some of the judiciary, there's going to be a whole bunch of legal challenges. But guess what? Everyone loves a good legal challenge. All right, that's all I got. Let's do some questions.
Okay, Matt, thank you. And I wonder if you've ever considered starting your own talk show for these kinds of issues. Thank you very much for that and the wide-ranging views. But we have questions coming from students first. And the first one is, I think it's really for Diane, but it's also for everyone. The Trump administration has appealed lower courts saying that work requirements can't be imposed in the Medicaid program. And the question that is being asked is, if Mr. Biden were to win, what could he do about that? Would the states be able to continue with their appeals on their own without the Trump administration? Or does the effort fall to the ground, that there won't be work requirements under a Biden administration?
I doubt very much there would be work requirements under a Biden administration. I mean, the courts have ruled against them in many cases, and most of those require some sort of a waiver that has to be given by the federal government to the states to do it. So one of the reasons that they've moved forward under the Trump administration is that they favored them, they've promoted them, and they've tried to get states to come in and get waivers. I think a lot of the future will not include work requirements if someone like Tim Westmoreland is put back in charge of the Medicaid program under a Biden administration.
That's not going to happen, but someone like, perhaps. We'll leave it at that for a second.
Tim, could you address the question of the flexibility that a new administration would have to revoke the waivers that the Trump administration conferred for work requirements?
Well, I'd have to go back and look, but my view on it is that since those waivers have not yet been allowed to go into effect, that they could probably be reversed relatively quickly. 1115 waivers for demonstration projects and Medicaid are completely at the discretion of the Secretary of HHS. And if the Secretary were to pull it back and say, you know, I want to revisit this, we need to continue to negotiate about what the contents are, I think they could be pulled back. If they've already gone into effect, if the state has already started implementing the waiver proposal, and Diane, forgive me, but I don't think any of them has yet gone into effect, have they?
Well, yes, they did, and then the court stopped it, so that at this point there are none actually being used or utilized.
So the Arkansas one isn't going. I think at that point that the reliance interest of the states might be able to say probably go away in the face of the discretion that the Secretary has.
And for example, with Kentucky, when the governor changed, the governor himself, the new governor came in and said, I don't want these work requirements, which mooted the court suits.
Yeah. So next, somebody's asked, another student is asking, single payer is often proposed as a solution, but the amount of healthcare, the amount of money that healthcare costs has continued to go up. What do the three of you think might be adjustments to the current healthcare system to control costs? And I guess I would reframe that question a little bit to say, even if you're not pursuing single payer as a new response, what would you do to control costs within the healthcare system? Gregg, you want to start?
Sure. Serious cost control is the one topic that both parties are agreed to be afraid to touch. One element that might have achieved a serious bite of cost control in the private marketplace, the so-called Cadillac tax, the tax on very high-priced health plans, has been repealed. There was bipartisan support for that. And the entity that was supposed to have the authority to set limits on, or to at least propose limits on Medicare spending is off the table as well. And so that's all probably going to be a matter for the private sector for the foreseeable future. It's really important, I think, here to make a distinction that might seem obvious, say, to the students in this course, but really gets lost on the news media and gets lost on our politicians as well. And that is the distinction between the prices that people see in the form of premiums and in the form of out-of-pocket payments for medical care and for drugs and devices, those prices versus the actual cost of care. There are a whole bunch of reasons, a whole bunch of factors that push premiums up, push deductibles and copayments up that aren't necessarily related to the chronically rising underlying cost of medical care. We certainly need to get command of these other kinds of factors, and Matthew has spoken to some of those. But in addition, we need to get a grip on this dynamic by which insurance is rendering it profitable to achieve tiny marginal increases in benefit at enormous additional cost. The only way that I think we can begin to make progress on this front, and my colleague Neil Sukatme and I have written on this and will continue to write on this, is by linking payment as well as patent protection, IP protection, to therapeutic value, something that we talk about doing, but we really haven't begun to do.
Matt, do you have something you want to add about cost control?
I mean, I was gonna say what Gregg said. You know, the there has to be something done on the other side of the equation, because as an HIV person, I constantly talk to insurance companies and drug companies, and they both blame the other one. And they're both in the wrong, but it would it takes some sort of massive market force to bring them down, or for us just as a society to decide that we don't think healthcare should be an entirely for-profit industry, and that some things are beyond that. And we're going to do things that help bring it down. HR 3 attempts to do that by making some money. That was the House's drug pricing bill. But there are questions about where some of these costs kind of balloon in, and neither party actually wants to write legislation to deal with them. They both kind of just want to say, well, the other party's not doing it, and these things are bad. And it's one of those like politician pass-offs. But I think people need to hold their feet to the fire and saying, no, both of you can do something about insurance companies. Neither of you are. Why aren't you?
Okay. And Diane, I know you've made a career of talking about cost containment in one way or the other. So what would you add?
I think that part of it is that we have to really reorient our healthcare system from being one that favors medical care and doesn't do enough of public health and preventive services. And that we've seen from, again, the COVID situation, that our public health infrastructure has been allowed to really dissemble and it's resourced poor. And so I think we also need to have some realignment of our priorities of what we're funding and what we're supporting. So I would put much more emphasis on trying to get people healthier and to get them into a better system that has public health protections and that also prepares us for things like a pandemic such as this.
Can I just underscore something Diane mentioned that's really important? There are authorities under current Medicaid law that permit allocation of resources to address some social and economic determinants of health. There are authorities under the ACA as well. And because of a battle over the so-called cost-sharing reduction subsidies for lower income people who obtain insurance via the health insurance exchanges, the Obama administration was virtually forced to allocate money from a fund that could have gone to social and economic determinants of health, to allocate money from that fund to pay insurers the cost sharing reduction subsidies because of some glitches in the drafting of the ACA that didn't make it clear that these monies should be paid from other sources. So if there were a way around that, we might well be able to creatively use Medicaid and ACA authorities to address social and economic determinants of health.
Yeah.
It's in the weeds, but it's important.
It's important.
Those are good weeds, Gregg. I'm glad that you brought them up. It's something that needs to be revived and revitalized. So Diane, there's a question from a student of whether you think there's still increasing public support for Medicaid, and what do you think needs to be done to reform it moving forward, regardless of which administration is going in?
Well, I think that the public support on Medicaid has grown over the years because the program's reach has grown so substantially over the years. And when we do public opinion surveys at Kaiser, we found that more and more people either themselves have at some point been on the Medicaid program, especially because in recessions, people lose their health insurance and end up unemployed and on Medicaid. They have children who have benefited from being on Medicaid or the CHIP program, and that now covers 1 in 4 of America's children, so that's a broad reach. And they know that in the case of the Affordable Care Act and the Medicaid expansion, what a difference that has made to people who need care or who have not had medical care in the past. We used to have to stand in line at these health fairs to try and get one annual checkup. So I think that what we've seen is that as the program has grown, more and more people have been touched by it, they understand it, and they value it. And even when we do polling in states that have not expanded Medicaid, there is a large section of people who say, well, we think our state should expand, even though the politicians don't necessarily agree. what I think needs to happen to Medicaid in the future is I think all states need to have covered everyone under 138% of the federal poverty level, and not to have expansion in non-expansion states. I think the program needs to do more to look at the underlying social determinants of health and how to better address those. And I also think the program really needs to move on another area that was so horribly exposed during the pandemic, which is to figure out how to better deliver long-term services and supports and to protect people in long-term care facilities. So I think long-term care reform, which is always on the back burner, is increasingly something that we need to focus on, both from a quality perspective as well as from an access perspective.
Thank you. Matt, question for you. Can you expound further on federal government held patents? Now, I bet you can, actually. Do you see a future where government itself manufactures drugs? Or...
Absolutely. One, showing all my cards, I am a Warren Democrat. Elizabeth Warren has a wonderful plan with Jan Schakowsky on doing this exact thing of creating generic drugs. We need to get into the space, because one of the things that most people do not realize is about 70% of drug development happens at NIH. Basic science research is really important. And then we pass those patents off to other people who take them to the further clinical development stages and make huge amounts of money. And then we just pay again, because our tax dollars already paid for the original research. You can see this on cancer drugs. You see this with everyone's favorite drug, insulin, that just seems to never, we see this with HIV drugs. It moves in a number of spaces, and we just don't need to be doing this. And especially in a world where the way that we give people patents and the way that patents are obtained these days, it's more and more based off of creating situations where people create Me Too drugs that actually create some sort of blockbuster that improves your care. And then you get to charge a huge fortune on, I'm just doing slightly better than before. So we've got to figure out some way to do this. We keep extending patent rights via our trade policy, which is also incredibly unhelpful. So it's going to take some patent reform. Now, patent reform is never going to be easy. You get a whole bunch of people involved, and drug patent reform is going to have a lot of money involved. Big Pharma's got a lot of cash. But if we don't do something, it will continue to be untenable, and we'll see situations like a Regeneron antibody could become, frontline standard of care. And I say that because the Regeneron data looks very good. But when your frontline standard of care, which is based off of research that we already did and paid for, is now being charged to the poorest in our country that are getting paid for out of their Medicaid dollars, which is more of our dollars, for an inflated price, like, why are we doing all of this? And so hopefully that kind of pushes us to an area.
Thanks. And yes, many of those things, although it's going to take a while to bring them together in a divided Congress and a divided administration. For all of you, from one of the students, assuming Mr. Biden wins, are there administrative actions that he and his administration can take to address affordability and coverage gaps? Lots of the things that were talked about in the Biden platform were about things that would require the Congress to change statutes or to provide money. Are there things that administratively that the Biden administration, that a Biden administration could do along the way? Diane, you want to start?
Well, certainly I think that they could go back to all the changes that have been made to regulations under both Medicaid and Medicare and try and look at which authorities they could use more effectively to help people instead of giving them work requirements or other things. So clearly one agenda has to be to go in and to review what you can do administratively. I think there's a great deal that could be done on social determinants and trying to address those through special initiatives under the Medicaid program. I think we also need to really look at the impact on safety net hospitals, the public health system and the clinics, and see where we really need to rebuild that system so that it's more able to address that. And so what you get when you're dealing with public health service programs is a lot more ability to move money around and to target to needs. So I think really to assess where the greatest needs are and try and get those dollars going. And then finally, to try to figure out some way and mechanism, whether it's the public option that Biden has talked about or another way to get the states that have not expanded Medicaid to do so. And some of that might be to put some new incentives out there in the form of waivers that they can't really waive the federal financing is the problem. And the reason states like to go ahead and do things is when the federal government will pick up the tab, but that may be an area where they could at least begin to think about providing some incentive through legislation for some of those states to go forward or to cover them under other means, even if it's under the existing matching rate.
Gregg, administrative activities?
This is a follow-on. First of all, I think that the administrative unraveling of a whole lot that the Trump administration did to make the insurance exchanges less functional is going to be a hugely important project. And there's lots of little items ranging from resources that are made available for navigators to periods during which enrollment can occur online, to possibilities for buying cheap health plans outside the exchanges so that young, healthy people come out of the exchanges. So-called temporary coverage has now been extended to close to 3 years. There's a long laundry list of those kinds of regulatory changes that would benefit, well, in my view, from being unraveled. In some cases, it's going to be possible to challenge those that unraveling in court. And with the federal judiciary, which is now somewhere between 1/4 and 1/3 filled with Trumpist judges at the appellate court level, there are going to be obstacles for not just the next 4 years, but for decades to come. I did want to briefly mention an aspect of Medicaid expansion that's really awkward to talk about, but that I think has to be part of the conversation if we're being authentic about this. Raising obstacles to Medicaid expansion, creating work requirements, et cetera, euphemistically called community engagement requirements, it is, dare I say it, in no small part, a form of racial dog whistle. There is a narrative out there. If you look at the map of states that have not expanded Medicaid, they're in certain places. There's a narrative out there that certain people are, well, to put it bluntly, more lazy, et cetera, than others. That narrative gets articulated in dog whistle fashion via these work requirements, via refusal to expand Medicaid, and the powerful incentives that states like Texas have to expand Medicaid. Look what they would do for their own health systems. Think of the hundreds of millions of dollars of federal money that would come in. Those incentives aren't strong enough to drive expansion. And so it's that narrative, which is in no small part race-based, that we're somehow going to need to find a way to get at. I'm not super optimistic short term, but that's a huge long-term challenge for our country.
Thank you. And Matt, last word on what things could be done administratively without the Congress?
I mean, I think you've got a lot of authority in CMS to make a lot of changes, and just really, it's surprising. The Affordable Care Act never actually got to run the way it was designed. And so anyone moving back towards like some of the ways that it was designed that never got implemented would be really helpful. But there is a whole bevy of policy in there that can happen for students who are bored, and I really mean bored. If you download the Affordable Care Act bill as a bill and just search the word Secretary shall, you will see a whole bunch of authorities that have been put in this thing that could really help contain costs, figure out how do we target programs better. I mean, I think in data collection alone, you could figure out how do we actually need to be directing programs to meet challenges and places where we're seeing inequity. And that would, over a budget year window, so a 10-year window, would save costs in that run. There's a bunch of things that got scored by CBO that we've never gotten to take advantage of because we just have hammered at not letting it be a thing. but you could change a lot of that.
Okay, thank you. It's been a great panel with a lot of ideas thrown out and really making clear how high the stakes are for the next 2 days for health policy and health legislation. But it's time to go. And Larry, I was hoping you had a few last words, concluding remarks.
Yes, first to thank you, Tim, Diane, Matt, Greg, just a fantastically well-informed panel. I mean, I think we've been making the assumption that we're going to have a divided Congress and possibly a Democratic administration. If that were true, a lot of our discussion has been about what administrative rules we could use. And we also talked about the Supreme Court. Now, it's a conservative court, but the court has shown enormous deference to the executive branch. And I wonder if that would continue or whether it wouldn't. It shouldn't matter which administration it is. So we've talked everything about COVID through to Medicare and Medicaid, through to the Affordable Care Act and the social determinants of health. And so, in relation to all of them, let's take the social determinants. We've spent most of our time thinking about HHS authorities, but what might a Biden administration do with housing, education, poverty, other areas that have and race, law enforcement, that have such enormous impacts on the public's health? That's something I think that also strong action could be taken. We've also not talked about climate change because climate and health have enormous intersections with them. But it seems to me that if I were to distill what everyone was saying, there's a really great thought piece that we could do together about what, given a divided Congress, what a Biden administration could do administratively in healthcare, housing, climate, other areas that have such profound implications for health. But I just want to stop and thank you. We've hit 4 o'clock. Georgetown Law now has a session on a post-election discussion, which we've promised our students that we would allow them to attend. So thanks so much. It's been a great conversation. The conversation will only begin and it'll become very clear over the next days what the possibilities are or are not. So thanks to all. Thanks to our audience, to our students. And for our students, we'll see you back here next week. Bye, everyone.